we have started this course, and this is the third session. This was actually in-house session, which after the initiative by Professor Salman Shri was taken online. Today we will start with Dr. Yusuf, who will briefly talk about anatomy of the temporal lobe, followed by Dr. Rafay, who is the senior registrar, and he'll talk about the surgical approaches. I welcome Professor Khalid Mehmood, Professor Khalid Mehmood is the expert, and we'll welcome Sir you. Yusuf, can you start?
Okay, I'll be sharing my screen now. Just give me a minute. Screen. Can everybody see the screen?
Yes, we can.
So it will be just a short recap. We discussed about the surface anatomy of temporal lobe, and we mentioned that the lateral surface of the temporal lobe is made up of three gyri: the superior, middle, and inferior. Superior being bounded by the Sylvian fissure and superior temporal sulcus, middle temporal gyrus by superior and inferior temporal sulcus, and finally we have the inferior temporal gyrus that not only forms the lateral surface but also the basal surface. So this was a coronal section of the brain in which we discussed that this was a coronal section along with axial cuts at the level of the midbrain, and we mentioned that the medial surface is occupied by three vertically oriented tracts of neural tissue, which we can appreciate are the inferior most is the white structure, which is the parahippocampal gyrus. Then we have the dentate gyrus and the
Dr. Yusuf, can you use a pointer while you explain?
Okay. I'll try, sir, because I'm currently doing it through cell phone, but I'll try to use the pointer. And this is a view from the inferior surface of the brain. In the inferior surface of the brain, we can appreciate that the most conical projection, as you can see in the left diagram, we can see the labeled anterior segment, and then we have the posterior segment. So the anterior segment is the anterior medial surface of uncus, and the posterior segment is the posterior medial surface of uncus. The anterior medial surface of uncus is in proximity to carotid cistern. So there we will have in proximity carotid artery and the proximal branches of MCA. The posterior medial surface is in proximity to the crural cistern, and it will contain the PCA and anterior carotid artery. Now, this is again a coronal section of the brain in which we can see that the medial most part is made up of uncus, and then we have the amygdala, as we have seen over here. There are two major structures that occupy the interior or the bulk of the temporal lobe. We have talked about it, that's why I'm just brushing rapidly through it. In the last lecture, amygdala and hippocampus. The amygdala occupies the central core. There is no exact demarcation, but the superior wall of the amygdala tends to blend in with the claustrum and globus pallidus, as we can appreciate over here. And medially, it is covered by the uncus apex, as you can appreciate. Inferiorly, there is the hippocampus. If we look at it from the sagittal section through the temporal horn of the ventricle, we can see that amygdala is also forming the anterior wall of the temporal horn of lateral ventricle, whereas the hippocampal head is occupying the inferior aspect, where it is forming the floor of the temporal horn of lateral ventricle. And both amygdala and hippocampus are separated by the presence of a small recess known as uncal recess. Now, this is a very good diagrammatic presentation of the medial wall of a coronal cross-section of the medial aspect of the temporal lobe. We have already discussed the lateral surface, the inferior surface, which we can appreciate, The inferior surface is made up of the collateral sulcus and occipitotemporal sulci. The collateral sulcus is separating parahippocampal gyrus from the fusiform gyrus, which is also known as occipitotemporal gyrus. And the occipitotemporal sulcus is separating uh, fusiform gyrus from the lateral inferior temporal gyrus. The medial surface, as we can appreciate, is made up of three structures: the parahippocampal gyrus, dentate gyrus, and the uppermost fimbria. And we also appreciate that this is the posterior part of the uncus. So there is an upper part, lower part made up of parahippocampal gyrus, and the upper part made up of hippocampus. And we can appreciate the three diagrammatic arrows pointing towards the hippocampus, which are completely gray because of the high concentration of neurons or pyramidal cells, which are referred to as the Eman horns. So I hope this was a very brief recap of the basic anatomy. So we'll be move on to Dr. Rafay, who will then continue on with the clinical anatomy. Thank you.
Thank you, Dr. Yusuf. Dr. Rafay.
Hello everyone, I am Dr. Mohammad Rafay, and now I will be discussing the surgical approaches to the temporal lobe. Now, a quick review of the history of the temporal lobe surgery. In 1890s, Jackson and the Coleman, he was the first one to describe the twisting movement and the dreamy state that are being associated with the mesial temporal lobe lesion. And in early 1915, Penfield was the one who used electroencephalograms and the electrocorticography to demonstrate relation between the epilepsy and the medial temporal lobe pathology. Later on, the Falconer and the Morris describes the early version of the temporal lobe surgery that forms the basic of the modern anterior temporal lobectomy. And after that, Niemetz was further modified this technique and includes the medial temporal lobe resection, hence called the anterior medial temporal lobectomy. Now, for the temporal lobe surgery, the key point is to identify the patient who are going to get benefit from the surgery. You have to localize the lesion and localize the focus of the seizure, and obviously you have to weigh the risk and the benefit before going to the surgery. The major indications of the temporal lobe surgery are epilepsies and the temporal lobe tumors. Around 80% of the patient who has a medically intractable seizure, they demonstrate the focus of the seizures within the anterior part of the temporal lobe. And an important point to remember is the duration of the symptom. If the patients come to you with the longer duration of the symptom, there is a poor post-operative seizure outcome. And if the duration of the symptoms and the surgery the duration of the symptom is shorter, the post-operative seizure control is good. Now, the temporal lobe surgeries is divided basically into 4 types. The first is the standard en-bloc anterior temporal lobectomy. The second is the anterior medial temporal lobectomy. Third is selective amygdalo-hippocampectomy, and 4 is lesionectomy. In the first one, in the first surgery, we remove the lateral neocortex of the temporal lobe, including the medial structures. These lateral neocortex includes the superior, middle, and the inferior temporal gyri, and the medial structures include the hippocampus, parahippocampus, and the amygdala. The second one includes is the anterior medial surgery. In this surgery, we spare the superior temporal gyrus, and the rest of the steps are same. The third is selective amygdalo-hippocampectomy, in which we totally spare the lateral neocortex and we do the dissection on the medial part of the temporal lobe. The fourth is lesionectomy. It depends upon the presence of the lesion within the temporal lobe, and we have a classification for this, which we'll discuss later in our presentation. Now, starting with the position, the patient should, for the position is for the anterior lateral temporal lobe surgery. The patient should lie supine, head tilted on the opposite side and fixed with the Mayfield clamp. The shoulder rod is placed on the ipsilateral side and secure all pressure points. Here, the same position, as you can see, the patient is lying supine, head fixed with the Mayfield and tilted on the contralateral side. You can note the extension of the head, which is around 50 degrees, and it is of quite importance because once you reach the medial side of the temporal lobe, and when you are working on the hippocampus and the parahippocampus, this extension, this helps you to keep your view in line with your microscope. Now, for the incision, you can either give a inverted question mark incision or you can give a linear incision. The inverted question mark incision that starts just 1 or 1.5 centimeter in front of the tragus and goes upward and posteriorly up to the superior temporal line and goes forward up to the hairline. The posterior limit of this incision is marked by an imaginary line that is starting from the mastoid up to the vertex. Do not go beyond this line because you do not need it, and do not fall short of this line because it will obstruct your view and it will make your dissection difficult. Now for the linear incision, same, you are going to start in front of the tragus 1 or 1.5 centimeter and go upward straight up to the superior temporal line. You can always turn your incision towards the forehead in order to increase your exposure. So after giving a skin incision, secure the skin edges with the hemostatic clips and do a temporal muscle dissection. While dissecting the muscle, you have to keep in mind not to coagulate and not to damage the superficial temporal artery. You can always leave a longitudinal strip of the temporalis muscle, as you can see here along the superior temporal line. So it will help you in the closure of the craniotomy wound. Second, when you raise the muscle flap and the skin flap, this you can see a glistening dura. Before doing the durotomy, you have to drill the sphenoid ridge, so it will make your vision better and it will help you while you are working on the anterior part of the temporal lobe. So you open the dura in the curvilinear fashion. The base of the dura should be towards the sphenoid ridge. Reflect the dura on the muscle flap, and this is the view you will see. Superiorly, you will have an inferior frontal gyrus, then you have a Sylvian fissure, then below it you will have a temporal lobe. Look for any major vessel and try to save them. Now you identify the superior temporal sulcus and then mark the middle temporal gyrus. Now, start your dissection by finding the middle temporal gyrus and by marking your posterior limit of dissection. Take a dandy cannula and measure the distance from the tip of the middle temporal gyrus. You can dissect on the dominant side up to 4 centimeter without giving any deficits, and you can go up to 5 or 6 centimeter on the non-dominant side. So mark the posterior limit of your dissection by using the bipolar cautery, and then go deep directly up to the arachnoid of the middle cranial fossa. So you have to take this middle and the inferior temporal gyrus, which is present on the lateral surface of the temporal lobe. This is the diagram. As you can see on the right side, this is the lateral surface of the brain. This marks the limit of the dissection on the lateral surface or the neocortex. You dissect through you take the middle temporal gyrus, you do the dissection of the inferior temporal gyrus, and the inferior limit is up to the collateral sulcus. You also take a part of the fusiform gyrus. Now, after dissecting through these lateral neocortex, you go anteriorly and subpially and dissect 1 or 2 centimeter of the superior temporal gyrus, starting from the tip of the temporal lobe. Another view, the coronal section of the brain. Here you can see the your limit of the dissection that is involving the middle and the inferior temporal gyrus, a part of the fusiform gyrus, and going up to the collateral sulcus. The arachnoid of this sulcus will define the inferior limit of your dissection. Now, after this, some of the surgeons, they prefer to open the temporal horn while doing the cortectomy, and some of them do not prefer to open it yet. They open it in the second step of dissection, that is the medial dissection of the temporal lobe. So for the medial dissection, the localization of the temporal horn is very important. So by this, you have done with the dissection, first step of dissection, that is the dissection of the lateral neocortex. As you can see here, this is the cadaveric specimen of the brain. Here is the frontal lobe, and this is the temporal lobe. You can see the superior, middle, and the inferior temporal gyrus. A part of the middle and the inferior temporal gyrus has been removed to show the inferior limit of the dissection, that is the collateral sulcus, and this is the fusiform gyrus, which is also included in your dissection. Note this slit-like structure. This is the temporal horn of the lateral ventricle that is present just beneath the middle temporal gyrus. So the landmark is, you measure the distance from the tip of the middle temporal gyrus, which is up to 4 centimeter, and at that point you go deep up to 3.5 centimeter, and you will enter into the temporal horn of the lateral ventricle. I'll be repeating it. If you can mark the location of the temporal horn on the lateral ventricle by measuring the distance from the tip of the middle temporal gyrus and mark it at the 4 centimeter. 4 centimeter from tip of middle temporal gyrus, start dissecting and go deep up to 3.5 centimeter, and you will enter the temporal horn of the lateral ventricle. This localization of the temporal horn is of quite importance, which we'll discuss later. So once you have done with the cortectomy, you have left with the temporal stem and the medial temporal structures. You go deep 1 or 1.5 centimeter into the temporal stem, and you will enter the temporal horn of the lateral ventricle. How you can locate the presence, the location of the temporal horn? For the one which I have already described. The second method is that when you are doing the dissection of the lateral neocortex, you will encounter this bony projection which is present in the base of the middle cranial fossa. Your temporal horn will lie posterior to it. The third one is that you mark it, you locate it preoperatively by using the scans, and the fourth is you locate it intraoperatively by using the neuronavigation. So once you have opened the temporal lobe, you can see the glistening surface at the ependyma of the temporal horn. And if you open the roof of the temporal horn, this is the view you get. This here is the frontal lobe, and this is the temporal lobe. Apply 2 retractors, and one on the frontal lobe and the other on the temporal lobe. Do not try to be too aggressive while applying the retractor in the frontal lobe, because you may damage the external capsule, the lentiform nucleus, and the basal ganglia. And thus apply second retractor on the temporal lobe in order to lift it up. You have to hook it up and lift the remaining part of the temporal lobe. Now here begins the second part of the dissection, that is the dissection of the medial part of the temporal lobe, also known as the amygdalo-hippocampectomy. Once you have opened the roof of the temporal horn, this is the view you get. You can see the gush of the CSF coming out from it, and you can see the choroid plexus. Do not coagulate the choroid plexus. Do not try to be aggressive near this structure, because just beneath it and just deep that is going through there, and the head of the caudate. So if you damage the optic radiation, your patient will get contralateral superior quadranopia. So as described by Dr. Yusuf, this is the temporal horn. This amygdala and the hippocampus form the anterior and the inferior medial wall of the temporal horn, and see how the optic radiation are arranged within the loop of the within the roof of the temporal horn. Here we have a choroidal fissure and the choroid plexus. This is the basal view of the brain. You can see here this structure is the hippocampus and this is uncus. The part of the uncus has been removed. Here you can see the amygdala within the anterior part of the uncus. So this is the temporal horn. As you can see here, this is the choroid plexus. This is the hippocampus, the head, body, and the tail of the hippocampus. And this black dot you can appreciate here is the inferior choroidal point. This point has a very key importance while we are doing the amygdalectomy, which we'll discuss later. And this is the point from where the anterior choroidal artery enters into this region. As quickly going through this, as Dr. Yusuf has already told us, how these medial structures are closely related to the important structures like the third nerve, the peduncle of the midbrain, the crural cistern, anteriorly we have the carotid cistern. This is another view of the temporal lobe, just to demonstrate that how these fibers are arranging, forming a loop and arching over the roof of the temporal horn. So you have to be very cautious and very careful while dissecting around the roof of the temporal horn. Another basal view, this is the uncus. Here you can see how it is closely related to the posterior cerebral artery, giving rise to the anterior choroidal artery and entering into this region at the point known as the inferior choroidal point. So going back to the this diagram, on the left here you can see we start the hippocampectomy, the second step of our dissection. We identify the cleft which is present between the amygdala and the hippocampus. We start dissecting from here. We go directly deep up to the arachnoid membrane and we try to save it. We do not penetrate it, otherwise you will end up opening the crural cistern and you may damage the posterior cerebral artery just running beneath it. Now you start dissecting from the head of the hippocampus. You roll it on itself or laterally, and you will see some perforators that are supplying the base of the body of hippocampus. Here you can see it. If you start dissecting the hippocampus, these are the perforators that are supplying the body of the hippocampus, coagulate them and cut them. Now free the hippocampus from all sides, from the lateral as well as from medial side. Suction the fimbria so you can free it and you can do the dissection. After taking this head and the body of the hippocampus, adjust your retractor, which is on the temporal lobe, and adjust your microscopic view and look beneath it and remove any remaining part of the hippocampus. Once you have done it, you will be left with the amygdala. So before doing the amygdalectomy, you have to localize the inferior choroidal point. This is of key importance because you have to localize it, and you go for anteriorly and dissect the sylvian fissure and trace the middle cerebral artery up to the knee of M2, the second part of the middle cerebral artery. Then draw an imaginary line in between these 2 points and always try to dissect or inferior to this line. Do not go above. Why? As we have discussed earlier, this is the coronal section of the brain. This is the uncus. Here you can see the amygdala, the darker nucleus formed by the pyramidal cell. As you can see, just above it, there is important structures like globus pallidus, claustrum, and the putamen. So, and there is no proper demarcation and no proper boundary between these two structures. So, if you are too aggressive while dissecting the amygdala, you may end up destroying any one of the structure. So, you have to stay below this line in order to prevent these structures. Remove the amygdala by using the cautery section or CUSA, and always leave some tissue over here, so you do not open the arachnoid and you do not enter into the carotid cistern. Now you have done with the amygdalectomy also. The other important point to remember is what happens if you miss the temporal horn. As you can see in this diagram, this is the temporal horn of the lateral ventricle, and see how closely it is related with some important structure like roof is formed by the optic radiation. Here we have the head of the nucleus, posteriorly we have the thalamus, and then medially we have the fimbria. So if you miss it, you definitely damage any one of the structure in order to trying to find it. So how to localize it? As we have discussed earlier, mark it preoperatively on your scan, use neuronavigation, and use two surface landmarks that we have discussed already. Now you have done with the uh, basic temporal lobectomy and amygdalohippocampectomy. Now, if you're talking about the selective amygdalohippocampectomy, the only selective dissection of the medial part of the temporal lobe, these are some corridors from where you can do the dissection while sparing the lateral neocortex. As you can see, these corridors are either transsylvian, transsulcal, transgyrus, or subtemporal. So this Sylvian approach was described by Yazirgil in 1982. Roger described it in 1992, the transsulcal approach, and Niemer described the transtemporal approach in 1958. While these are some temporal approach which are also being described. Now, talking about the transcortical or transventricular approach, for this, you have to give a small curvilinear incision in just in front of the pinna, do a small craniotomy, and localize the middle temporal gyrus by using the neuronavigation. You give a 2 to 3 centimeter long incision, and that incision starts 4 centimeter back from the tip of the middle temporal gyrus. You dissect deep, and you will enters directly into the temporal horn of the lateral ventricle, and the remaining step of the medial dissection are the same. Now, for the TRANSSYLVIAN approach, as we have discussed, Weiser and Yazirgil described it in 1982, and in this approach, we have to dissect the Sylvian fissure. So there is always a chance of damaging the vascular structure which is present in the Sylvian fissure, but it completely avoids the new cortical injury. But you have to dissect a part of the temporal stem in order to reach the medial part of the temporal lobe. As you can see here, this is the lateral temporal cortex. This is the medial temporal lobe. This is the Sylvian fissure. So the corridor is through the dissection of the Sylvian fissure. You go here and you make an incision in between the two temporal opercular arteries. After making this incision, you have to take this temporal stem in order to reach the temporal horn of the lateral ventricle. If once you have reached it, the remaining step of dissections are same. So through the TRANSSYLVIAN approach, you have an excellent view of the anterior temporal structures, while the posterior, there is some difficulty in approaching the posterior part of the medial temporal structure, that is the hippocampus and the parahippocampus. Now, for the subtemporal approach, the rationale of this approach is to totally spare the neocortex and to avoid any incision in the temporal stem, which will definitely minimize the visual deficits for the patient. It has an excellent overview for the posterior structures, that are the hippocampus and the parahippocampus, but there is some difficulty while approaching the anterior structure, that is the uncus or the amygdala. As you can see here in the subtemporal approach, we usually go from the base of the middle cranial fossa, and we retract the temporal lobe, and in this approach there is a quite a good amount of retraction has been used. So there is also a chance of damaging these two structures, that is the inferior temporal gyrus and the fusiform gyrus. You go beneath it and you identify the collateral sulcus, and you start your dissection from here. Then you first dissect the anterior structure, that is the amygdala, and go posteriorly to involve the hippocampus and the parahippocampus. Here you can see a very small incision for the subtemporal approach that is present at the base of the pinna. You can do it with a small craniotomy, and and you can approach the collateral circus from here, but you have to use neuro navigation in order to identify the gyruses. Now, we have done with the first three approaches, that is the anterior temporal lobectomy, anteromedial temporal lobectomy, and selective amygdalohippocamectomy, and we have also discussed some corridors for the selective amygdalohippocamectomy. Now, if you are talking about the lesionectomy, this lesionectomy basically depends upon the presence of the lesion within the temporal lobe, and for which we have classified it into several regions. This is, as you can see, the inferior view of the temporal lobe. Here is the temporal cortex. This is the medial part of the temporal lobe. This is the temporal stem, and this is the temporal pole. If your tumor or the lesion is present in the anterior lateral cortex, it is classified as the 1A. If it is present in the posterior lateral cortex, it is classified as 1B. The posterior lateral cortex is just behind the temporal stem. And you have to be very cautious while operating in this region, because if you are on the dominant side, we have a language center here. So if your lesion is present in the anterior part of the temporal lobe, that is the temporal pole, you will classify it as type 2. And if the lesion is in the temporal stem, it is type 3. Now, for the medial structure, we have a type 4. If it is involving the anterior medial structures, it is 4A. If it is involving the posterior medial structure, it is 4B. So why this classification is necessary? So you can have an idea regarding the approaches of these lesions. If your lesion is present in the lateral part of the temporal lobe, either in a region 1A or 1B, you can go through the lateral transcortical approach. If it is present in the anterior pole, you can go through a pterional approach. If your lesion is present in the temporal stem, deep in the temporal stem, use TRANSSYLVIAN or the transsubpercular approach. If it is involving the medial side, for the anterior medial part, you go TRANSSYLVIAN or the transcisternal. For the posterior, you go supratentorial or infraoccipital approach. Now, this is all about the lesionectomy, the presence of the lesion on the temporal lobe. Now, these are some radiographs, and as you can see here on the left, the figure 1A, there is a lesion which is present in the temporal lobe. I would like to ask the participants, can anyone describe in which area it is present?
You can use the comment box to answer. The participants can use the comment box to answer.
Yes.
Or raise their hands if they want to. So which part of the temporal lobe is the lesion occupies? Anyone?
You can also tell it according to the classification, as we have gone through it.
So can you give some hints, Dr. Rafay? Because I think
yes,
it's turning out.
This is the temporal lobe. As you can see, this is the temporal pole. This is the lateral cortex, the anterior part of the lateral cortex, and as we have discussed earlier, this is classified as the 1A. So the lesion is present in the 1A location. So for the approach, we can use the lateral transcortical approach.
So Dr. Pravat has answers, and he said this is 1A, which is correct.
Yes. As you can see, this is another lesion which is present in the posterior part of the temporal lobe, just posterior to it, and we can also go through the same approach for this lesion. Now, any one of them can anyone describe the location and the approach which we can use for the resection of this lesion?
If you cannot classify according to what Dr. Rafay just tell us what part of the temporal lobe it is. Dr. Pravat says that it is 2. Can you go back to the diagram again once you show the classification diagram that you showed?
This is present in the region 2, which is the temporal pole. So we can approach this by doing a terional crinotomy.
And going transcortical?
Yes, transcortical. Moving on the other image, here you can see a lesion which is present deep within the temporal lobe. Can anyone answer which area is this?
So either the area or classify according to the numbers that Dr. Rafay just showed. Anyone? So we have can you this is 4B. Dr. Pravat says that this is 4B.
This is 3, which is involving the stem of the temporal lobe. Yes, this 3 is the stem of the temporal lobe. As you can see, the corridors are either transfilian or the transopercular. So moving on to the next one, this is the lesion in medial part of the temporal lobe. Can anyone describe the exact location of it, or either classified it according to the classification?
I think it's written on the scan.
Yes, can what is the exact location of the lesion? Is it in the anterior part or the posterior part? Yes, they are correct. This is in the anterior part of the anterior medial part of the temporal lobe, or for this we will go through a transsylvian or the transcisternal approach. Now the last one, the last one is the lesion which is present in the posterior medial part of the temporal lobe, and we can use either we can use supratentorial infraoccipital approach for approaching these kind of lesions. So thank you very much. If anyone has the question, you can just write it on the chat and we will answer it.
Thank you, Dr. Rafi, for an excellent presentation. Great demonstration of your surgical anatomy. So one thing that you did not mention is why was there a need for a selective approach when we already had an anterior temporal lobectomy, and why was there a need for a selective approach?
Because if your lesion is present, or if your focus of the seizure is in the medial part of the temporal lobe, it is better to save the lateral neocortex, because if you are working on the dominant side, you will have some deficits like memory, cognition, and the speech. So it is always better to save as much area as you normal area as you can. So these approaches are being developed in order to save the lateral neocortex. So we can work only on the medial side of the temporal lobe.
Thank you. I will request Professor Khalid to please add his comments and his views. Professor Khalid, I would request you to add your comments. So if anybody has any questions, they can write it in the chat box and we'll be happy to answer.
Khalid, please, we are waiting for your comments. Can you hear us, Khalid?
Hello.
Yes, we can hear you.
Yeah. I think there's a bit of interruption actually. Now you want me to, I think first of all, it was an excellent presentation by Dr. Rafay. I think he clarified the anatomical concepts and indications and everything. Now, from practical viewpoint, I would say that the most commonly done procedures for the temporal lobe are standard anterior temporal lobectomy for the non-dominant side. That's usually the right side. And if it's the dominant side, that's the left side in most of the cases. you actually save the superior temporal gyrus that you call the AMTL. For epilepsy surgery, we used to do a lot of amygdalohypocampectomies, but studies showed that your electrical activity actually spreads all around and the results are not as good. I'm just talking about the epilepsy surgery. So the generally trend was either to do the ATL or do the AMTL, sparing the superior temporal gyrus. Now, temporal lobe surgery can be two types. One is pure epilepsy, when there are no features of raised ICP, and the commonest is the medial temporal sclerosis, and you can have a hematoma, cortical dysplasia, you can have a ganglioglioma, you can have a migrational disorders, you can have a low-grade glioma, and sometimes you can have a like a malignant glioma involving the temporal lobe, and then you can have a sort of insular component spreading to the parietal lobe. So what I have seen that if you know how to do a nice anterior temporal lobectomy, you can remove a lot of tumor that looks like an insular with a big temporal component, because the Sylvian fissure is elevated in these cases. And if you hit the MCA artery, that's your medial extent. So you end up removing a lot of tumor, temporoparietal tumor, by just doing temporal lobectomy. Now, just few things about the surgical technique, how we do. The position is always the head is turned left for the right sided. I tend to do the question mark flap, and that's the Montreal variation. The superior limit is the superior temporal line, and you don't have to expose the frontal lobe. That's the Montreal, when your anterior extent just stops at the hairline and is little downwards. It doesn't go straight. And the most important component is actually the bony component. I would like to say that once we have removed the bone from tip of the middle fossa, if you measure with the brain cannula, the distance should not be more than 1 centimeter. If it's more than 1 centimeter, you actually have to nibble some more bone, because that would put less retraction and everything would be under vision. Because what happens, there are temporal veins that go to the base, and if you haven't done enough bony work, then you can avulse this vein and spend half an hour or 40 minutes stopping bleeding and so having a bad start. So very important point is that for the temporal tip, the tip of the temporal lobe, the bony work should be up till 1 centimeter if you measure with the brain cannula. It should not be more than 1. Similarly, when you measure with the brain cannula at the base, it should be flush with the base. So bony work is extremely important. You open the dura, and my technique is, first of all, I would free the temporal tip from any veins which I have mentioned. If I've done the enough bony work, the veins are visible under microscope or with a bit of the temporal tip retraction. If there are veins, you can buzz it, and so you deskeletonize the whole temporal lobe from the base, from the tip. If there are any veins, bridging veins, you take them. So this is free. The next thing is you have to decide whether it's the left side or right side. And if it's the left side, I have said you have to spare the superior temporal gyrus. So you work in the superior temporal sulcus. That's the transsulcal approach. If it's the right side, you actually go, you don't open the Sylvian fissure, but you just work just lateral at the top end of the superior temporal gyrus. You can say it's the transsulcal approach, and you can make a longitudinal cut. Now, the important point is to identify the vein of Labbé right at the outset. And it's very important on the left side. Anything going transversely from superior to inferior, about 5 to 6 centimeter distance would be a Labbé. It can't be anything else. And the distances vary, because if there's a tumor, the Labbé can be shifted backwards. So distance can be 6 centimeter even. It can be even sort of 5 centimeters. So very clearly you can see the Labbé, and if you make your corticotomy just anterior to the Labbé, that is the safest. You can't damage these patients. Now my next step is I have deskeletized the temporal lobe. I know whether it's at the right side or the left side. I actually enter into the temporal horn right at the beginning. That was my training. And you measure 4 centimeter or 5 centimeter just in front of the labbe, and you go into the middle temporal gyrus. You make a corticotomy, and at the depth of about 3.5 to 4 centimeter, you encounter the CSF. And once you encounter the CSF, I put my patty, and I know that I am in the temporal half, and this is a very advantageous step, because that would give you the depth, the posterior limit, number one. Number two, that would give me the depth. Where is the temporal horn? And I know that if I have entered the temporal horn, then obviously you can see the hippocampus and anteriorly it would be the amygdala. So once I have entered the temporal horn, I have demarcated the posterior limit just in front of the labbe, I have known the superior limit, then you do the corticotomy. Another very, very important point is, actually, when you're doing the medial corticotomy, I actually look for MCA right at the beginning. So, because the MCA would be your medial limit. If you don't look the MCA, you're going to leave a lot of tumor behind. So it's very easy, because as you enter with a microscope, you do the corticotomy on the medial side, and you keep on sucking with a sucker till you enter into the sylvian fissure. That's the transgyral approach. And the arachnoid is draping over the MC artery. So you hit the M2 segments. So that would be your medial segment, medial limit or medial margin of the tumor. So if you have insular component, you do a lot of suction because your MCA have been shifted medially. So you actually go through the tumor a lot way until you encounter the MCA. You put your patty on it, so that would define your medial limit. So you have freed the frontal side, you have demarcated the medial side by looking on the medial cerebral artery, and then as it was very nicely told that you work just slightly lateral to the MCA and go all the way deep down. Now, when you're going deep down, laterally you find the free edge of the tent, but between the free edge of the tent and the brainstem, there is a thin layer of arachnoid, and underneath there is the third nerve and there is a posterior cerebral artery. Very important point is that you should not violate the arachnoid, because if you violate the arachnoid, you're going to have the third nerve palsy. And there are small perforators and posterior cerebral arteries and oculomotor nerve. They're all draped by arachnoid and they're protected with arachnoid. So when you go vertically down, you hit the free edge of the tent, and then working along, then the free edge of the tent is your landmark, and you work along the free edge of the tent to actually do the inferior, free the inferior surface and do the inferior corticotomy till your posterior line meets, your medial line meets with the posterior line. You have already freed the front part and you have freed the lateral part, and you remove everything in block. So I have what I have removed. If I'm doing the left side, it's usually about 5 to 5.5 centimeter. If it's on the right side, it can be even 7. But as I have told, when there is a tumor and the tumor push the labbe backwards, so sometimes 6 centimeters is quite safe on the left side. So once I have actually cut it and blocked, then I turn upside down, and my lower surface with the parahypocampal gyrus, I make a cut with knife on the specimen. I'm just telling you. You can see very easily it's a hippocampus that has been removed and blocked. The amygdala has been removed and blocked. Hippocampus is pearly white. It's white colored. You can easily look under the microscope. And with the epilepsy surgery, you should try the maximum hippocampus. You make a cut at 5 centimeter, and you can actually turn backwards and suck with the kuza rest of the hippocampus. So this is an N-block excision of the lateral temporal lobe along with amygdala and along with hippocampus. So if there is any electrical activity apart from mesial temporal sclerotic part and is spreading around, you have actually dealt with it and it does not give you any deficit. Now, how to save the Myers loop in the tumors? My experience is that you should, when you are going backwards, you should stay at the lower level because if you retract upwards or you start sucking superficially, uh, this is arcing on the roof. So you can give a lot of deficit. So in expert hands, even if you have removed 7 centimeter temporal lobe on the right side and 5 centimeter on the left side, uh, sometimes quadrantenopia and superior temporal quadrantenopia, and sometimes not even that quadrantenopia, and you don't have any other deficits, to be honest. No dysphasia, even if you're doing on the left side. You really need to know your anatomy, and you should have assisted these surgeries, and you should be commonly doing it to be a very safe surgeon by doing left-sided temporal approaches. Anything else?
Thank you, Dr. Professor Khalid Mehmood, for your expert opinion. There's a question by Juan Miguel, and he says, what is your experience with conductive aphasia or semantic problems in left stem temporal ejectomy? Do you think it is permanent or transitory, especially when you do it, when you're not doing it awake without cortical and subcortical stimulation?
No. We're not doing awake actually. We don't awake. You just, if you're doing on the left side, if you stay in front of the labbe and if you spare the superior temporal gyrus, it is, I have not encountered. I have not.
Okay.
You should be, as I have said, reaching to that level, I would say I had assisted almost 100 temporal lobectomy to an epilepsy surgeon, Charles Polke. Okay, I was Charles Polke's epilepsy registrar, functional neurosurgery registrar at the King's College London, and his job was only to do the temporal lobectomy, epidural hypercumbectomy, or hemispherectomy, or multiple subfield transactions. And that. So, as a part of the epilepsy surgery, I assisted about 100 because we were just doing these cases on every list. So, you should be really assisting it, improve your anatomy, improve your knowledge, and then doing it as you have been taught. I mean, there are a lot of variations and modifications of the temporal lobe surgery based on one's experience. So that's how I have learned, and that's how I practice. And to be honest, even on the left side, I'm very confident whenever I'm doing it. I don't do awake, although I do awake surgeries for eloquent areas, but we don't do awake. But the chances of this dysphasia or a receptor component is really minimal.
Thank you, Professor Khalid Mehmood, for your expert opinion. If there's any other question from the participants, we'll take it now. Otherwise, we will conclude this session. Next week we will be discussing parietal lobe anatomy and surgical approaches. Any other question? So I think we conclude the session. I thank Dr. Professor Khalid Mehmood for taking out his time and giving his expert opinion on this surgery. Thank you, Dr. Khalid Mehmood, and we will see you next week. Thank you.
Yeah. Thank you very much.
Thank you.
Thank you.
Allah Hafiz.
Bye.